Good afternoon. Welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thanks for joining me today. So here's our agenda for today. So today I'm going to give you a brief update on pandemic-related issues. And then I'm going to be talking with Dr. Dave Kavanaugh, who is our ED Director for CGH, actually works for a company called Team Health that we contract out with. We're having some technical difficulties with Dr. Kavanaugh, so I hope we'll have Dr. Kavanaugh we'll have a very short broadcast if his technical difficulties aren't resolved. So we'll give it a go and see how we do. So I'm going to start with pandemic-related issues, and Matt is going to show you our chart for the week. This was as of last Friday, and that middle number that said that little green low thing, that's a nice thing to see. We haven't seen that for a while. So our number of cases is down to 141 per 100,000. Our positivity rate continues to go down. Hospital admissions are down, and unfortunately, there were a couple of deaths reported within the past week or so, but even those numbers are improving as the number of hospitalized patients go down. So continues to be encouraging stuff that we're seeing at the local as well as state and national level in terms of COVID. What I get every day from the Illinois Department of Public Health through the Illinois Hospital Association numbers look good too. The number of patients that are hospitalized with COVID as of yesterday were 699. That compares to, 4,400, I believe, at the peak of this particular surge. So down significantly. And the state percentage of positive tests is 1.4%, which is also very encouraging. One other item that I'll add, I'm not going to show a chart on this, but it's a little counterintuitive in terms of vaccines, and that this surge is really petering down, which is awesome. And so what am I talking about vaccines for? Well, I did happen to look at an article that was in the New York Times that I thought was enlightening. And basically what it did is they looked at number of cases versus number of deaths, vaccinated versus unvaccinated folks. And they compared it basically to states where they had a higher percentage of certain different type of voters. But long story short, it's not as much as you would think, if at all, of people that are vaccinated in terms of number of cases. But what definitely there's a difference with is vaccinated, fully vaccinated folks, which I would include having a booster as appropriate, and the number of deaths that we're seeing. And I only bring that up because if you happen to be or know someone who happens to be that bucket of people, there's my understanding is we're talking about 7 million Americans or so who have some type of health condition that makes them immunocompromised, whether they're on some type of chemotherapy, they've had a solid organ transplant. There are about 7 million of those folks out there. Definitely, if you're part of that group of folks, it still makes sense to get vaccinated, because even if the way it's trending now, even if this becomes more and more of an endemic type situation, from what I'm reading, I don't think we're going to not have COVID cases for the foreseeable future. And so if you're part of those group of folks, you want to do what you can. And it seems like the best thing you can do is make sure you're fully vaccinated. And anyone else who's say over the age of 65 and isn't in the greatest of health, make sure you're fully vaccinated even now. So that's the main stuff I wanted to share about the pandemic. Now, let's cross our fingers and see if Dr. Kavanaugh, by the way, as always, if you have questions, send messages my way and Dr. Kavanaugh's way, and we'll try our best to answer them. All right, let's see if we can hear Dr. Kavanaugh. We can see him.
All right. Hi, Dr. Bird.
Hey, all right. So far, so good, right?
Exactly. So far, so good. We'll see if this sticks. I'm real sorry about that.
Sorry.
I wasn't expecting this, and it just kind of popped up on me early this morning. But thanks for having me on here. I
Yeah,
appreciate it.
glad to have you. We had Dr. Kavanaugh probably a year or so ago, so nice to have him back. And just to reiterate, Dr. Kavanaugh actually works for a company that we contract out through CGH called Team Health, and Team Health provides the emergency room staff, physicians and nurse practitioners and PA that see patients at CGH. So Dave is the director of that program, and also does see patients in our ED. If you see Dave in the ED though, it's not a good sign, because Dave's shift is typically 7 p.m. to 7 a.m. So
Right. Yeah. If you see me, then you can't sleep. Right.
yeah,
Something
so
is
Dave's
keeping you from
our
sleeping.
night guy. He has a he I think you get done at 7, and like it's like around now, I think you've had your sleep for most of the day, right?
Oh yeah, yeah. Generally by noon we're up and running. Yeah.
Yeah.
Doing
More
what we got
power
to do.
to you. All right. So I have a list of questions we're going to try to take care of here in the next 15, 20 minutes or so, and
Sure.
see what Dr. Kavanaugh can enlighten us with. You ready, Dr. Kavanaugh?
Absolutely.
All right. Okay. So yeah, because you're on the front lines of the pandemic related stuff as in the ED, can you kind of, for those who are listening, how are things right now compared to how they've been with COVID in the ED?
Yeah, COVID makes the ED world very, very strange. We're used to historically some vacillation, ups and downs a little bit, but COVID will make it where you get very, very highs and then very, very lows. And we experienced a lot of the highs in November, December, part of January with Omicron. Just lots and lots of folks, jamming everything up, needing to be tested, feeling sick, all that. And then we had a abrupt stop. Within a couple of weeks, it just really stopped. And I was just telling you guys, I think it's been a number of weeks since I've offered anybody a treatment, a monoclonal antibody therapy, something like that. So right now we are kind of operating under the pre-COVID kind of feel. What we are seeing though, lots of influenza. I think a lot of people maybe didn't get influenza shots this year because of how prevalent COVID was, and that was what was on everybody's mind. But that is what we see, what probably 10 to 1 right now is influenza. So
Yeah,
the
the
volume
Redicare
are
folks,
down
I
now.
heard a report that I think it was a few days ago, they had like 15 in that one day, 15 patients that had influenza A.
Yeah,
So that's definitely right now the more prevalent infectious disease issue in our community.
it is. Unfortunately, it's, from what we've seen historically, it's not as severe. Right now, it's a lot of kids,
Okay,
and fortunately, they're relatively minor in their symptoms and their illness.
good, good. So I want to transition now out of COVID and talk about just kind of some common diagnoses or particular patients that you see in the emergency department.
Sure.
And the first one I wanted to talk with you about are patients who have something called sepsis. And before we go into details about how you go about identifying and treating that, can you just give the folks who are watching us a definition of what exactly is sepsis?
Okay, sure, sure. I think there's probably a lot of misunderstanding in the community about what sepsis is. People may think that just being really sick, means you have sepsis, but there are some very technical definitions. We have parameters as far as vital signs, your heart rate, temperature, breathing rate, combined with infection or concern for infection. So you put those things together, the heart rate and vital sign abnormalities, temperature, those are called inflammatory response syndrome. Okay, systemic inflammatory response syndrome. That's called SIRS. You add that with some infection, technically that is sepsis. So that can be a very broad spectrum of things, right? Minor to very severe. And the more severe you get, you develop severe sepsis. Severe sepsis can lead to septic shock. And I think septic shock is what people really equate with sepsis.
Okay.
My family member had sepsis, and really what they're probably talking about is septic shock. And that's really when the organ system that's involved in that infection, or even other organ systems, start showing dysfunction or shutting down. And that's kind of the whole spectrum from minor all the way to very, very severe.
Yeah. So tell me a little bit about how does your team, between yourselves and the other medical staff on your team, as well as the nursing staff, what do you guys do to try to identify? Because it's not like someone just shows up and says, "Hey, I have sepsis, by the way. Can you take care of me?" Sometimes it's not always. You have to tease that out. Can you talk a little
You
bit
do.
about what you all do?
Yeah, you really do. It isn't always obvious, and sometimes it is very subtle. And so really we have a lot of things that have been put in place um, that help us identify whether it's abnormal vital signs, whether it's, we have blood tests that help us identify whether you are developing sepsis or not. And just your general picture of someone after you examine them and see them, and what all these things together, that exam with their vital signs, with some of these blood tests, give you a picture of how sick somebody is, whether they're going to fall into this sepsis kind of presentation, and then how bad it is. We do have quality measures that we've put into place that help us identify it. We even have sheets that the nurses and the providers kind of check off as to the presentation, the vital signs, that help you put that together and say, okay, this person is either at risk for sepsis or they are developing sepsis. So you can then get to the treatment as quick as you can, because that's really
Yeah.
the key.
Yeah, and let's talk. The treatment's bundled too, in terms of you have like a checklist of things you want to do for patients. Can you talk about that for the folks who are watching as well, Dave?
Sure, sure. The treatment really, the mainstay of the treatment consists of getting antibiotics as quick as possible and getting IV fluids into people, because generally these people are sick, they're depleted of their volume, and they need antibiotics. Really, that's the thing, is as quickly as you can get appropriate antibiotics in these people, the better. And sometimes you have to go farther than just giving them fluids. Sometimes we have to give them medications that really help support their cardiovascular system by either clamping down on blood vessels to help raise blood pressure, or augmenting a heart rate to help with blood pressure. Um, but generally, it's getting those things in as quickly as we can.
Yeah, it's a pretty serious thing, and I don't know what the national numbers are, but I mean, it's one of those diagnoses that pretty high mortality for all things considered.
It certainly
Yeah,
can be. It certainly can be.
yeah,
And
yeah,
the quicker you identify it and start hitting those
yeah.
points, the less that is.
Okay, yeah. Okay, so I wanted just to talk about that because that's, from my perspective, one of the big buckets that the ED takes care of for really the patients that are really in need of emergency care.
Yeah.
I want to talk next about heart attacks, which in the ED world, I'm pretty sure you call STEMIs. So can you talk about what a STEMI is, Dave?
Sure, sure. Well, a heart attack, right? People understand a heart attack is when you have some sort of occlusion, a blood clot, or a piece of a hardened artery find its way down one of the arteries in the outside of your heart that feeds the heart muscle and blocks it. So then everything past that can't get blood flow, can't get oxygen, and that muscle starts to die. That's what causes the pain, and that's what creates all the symptoms that generally bring somebody in. So a heart attack can be sort of identified into a couple different ways, but STEMI is where we say, okay, this is a definition by what the EKG looks like. The EKG, is the stickies we put on people's chest to look at the electricity through their heart. And if it has a certain type of morphology, then that is elevation of an ST segment. And that's where the STEMI comes in, the STE, the ST elevation, MI is myocardial infarction. So that's the big heart attack, right? When people really talk about heart attacks, someone who's sweaty and
Yeah,
nauseous and clamping their chest, um, that comes. And so we try to identify that very, very quickly by getting an EKG on someone, that anybody that comes in with chest pain, we get an EKG on them very, very quickly.
yeah. I wanted to talk about that if we could. So, like, talk us through the process even before someone gets to the ED, to up into when they leave the ED to go to the cath lab, if you would.
Well, we would hope before the ED, let's say they're at home and they start exhibiting these kinds of symptoms, families would be aware of the chest pain the nausea, the sweating, those are very, very serious symptoms that need to be brought in right away. If somebody ends up coming in by because they're the call, usually oxygen on, they will give them aspirin as long as they're not allergic. Same thing with nitroglycerin if they're having pain and their blood pressure is reasonable to do that. And they will usually get an EKG in the ambulance and send it to us so we can get before they even, and if it looks like and we can actually start activating things before they even arrive and have the cardiologist ready, the catheterization lab ready. So it can be a very, very quick process.
So they get to you, and sometimes you identified them, sometimes you identify them in the ED, and then you're trying as soon as you can, because time is heart muscle, trying to get them up to the cath lab. And in that period of time, did you say aspirin, sometimes nitroglycerin, some blood thinning medicine sometimes? Those are the kind of things that patients are getting. Is that kind of the routine?
Correct. Yeah, it's pretty routine. It is specific to facilities and cardiologists as far as things after that, but that's kind of your baseline, your minimum, as long as their their blood pressure will support it. You don't want to give them nitroglycerin if their blood pressure is really, really low. But generally you want the nitroglycerin helps open up the blood vessels a little bit. The aspirin helps keep the platelets from being so sticky, so blood can flow a little bit easier through those areas that are closed up.
Yeah. So for the folks who are watching, the STEMI patients are a select category of folks, and we call it overhead page in the hospital about a STEMI, and it's a big deal, and we take it very seriously and do a really good job with that here at CGH. And that's a small component of patients who come in who have chest pain or chest pain-like symptoms. So can you talk about the rest of the patients who come in who you're trying to figure out if maybe they don't have not having an active heart attack, but have had some type of heart-related issues, and what the approach is for you and your staff when those patients come in?
Certainly. Yeah, chest pain is a really common complaint. Lots and lots of people come in with chest pain. Unfortunately, not many of them are these occlusions, these STEMIs. And so what we do we have protocols that are in place that are built out. A nurse sees a patient in triage that has chest pain, and they can put this order in, and it fires everything off immediately, really before I even see them. And we are looking for abnormalities in certain blood tests, chemicals that live in heart muscles that get released when there's bad blood flow to that heart muscle. We can start measuring that about 4 hours after something starts happening. And these numbers stay positive for days, really. So we start looking for that. We look for other causes. Does somebody have a pneumonia? Do they have blood clots? Do they have pleurisy or some other kind of musculoskeletal or even GI, like esophagus problems, can cause chest pain? So we need to look for all of those things while we're doing this. And sometimes all the tests come back negative, and we then can risk stratify people. How risky are you based on your age, your history? Have you had heart attacks before? Things like that, to determine whether this person can go home. Do we need to test them one more time as far as their heart tests go? So we have a pretty robust system in place to find those people that are at risk. Some of them need to stay in the hospital because they're too risky to send home, but many of them have a low enough risk factor profile that we can send them home with some follow-up, like they would follow up with you in the office, and you would then maybe stress test them or go, look in a different direction.
Good. Yeah, good. Thanks. Well, final diagnosis I want to talk about with you, and that is strokes. So another big emergency type of issue that you all deal with quite frequently. So if you would, walk us through that process for patients when they either call an ambulance or show up in the ED, and what you are doing to evaluate and assess them, and what things you have available to do that.
Sure. The stroke is a lot like the STEMI heart attack. We have an alert that we call overhead for a stroke alert if someone is either coming in by ambulance or they've come in the front door and the first person that sees them, the triage nurse or the first paramedic that sees them, really thinks that this could be stroke, we start activating things as quickly as we can. And the biggest thing you want to activate right away is to get a CAT scan of their brain. But people start considering stroke and think about stroke when there are the things that I think a lot of lay people would understand, whether you have a drooping face, whether you have weakness in an arm or a leg, speech difficulty, things that look like you're having problems with the normal flow of blood into your brain. And we then get that person right over to CAT scan, then right back to the ED where the blood tests are sent off and where we start making our determination if this is a stroke. And we have some nice handy bedside tools. The National Institutes of Health has a stroke scale that we can use that helps us define how serious a stroke is. And that then also helps us sort of risk stratify you when we're talking to specialists about the acute care of that stroke. And once let's say we say it's a stroke.
Yeah.
Go ahead.
No, I interrupted you. Go ahead, Dave. What were you saying?
I'd say once we think that this may be a stroke, we have a couple of options. We do have the help of a telestroke program through Northwestern that actually has a computer robot and a screen that a stroke neurologist can interact with that patient in our ED to sort of help us determine what's going on. Is this truly a stroke? How can we get them help? And then we also have the stroke specialists that we use up at Rockford at the larger hospitals that if we're very, very confident in this, we can talk to them on the phone and get somebody either beginning treatment here with clot busting medications, or if they're outside of a window for that, there's a time frame that we can use that in.
What is that time frame?
3 hours. So,
Okay.
Normally we usually go by 3 hours. If these symptoms are present for less than 3 hours and you don't have specific criteria that would exclude you from using this, then we try to get that in you. And that's a medicine that basically gets in your system and chews up clots, makes clots dissolve so you can bring blood flow back. Now, if you think about that, that's also potentially a risky drug. So it's something that we talk to the patients and their family members about. Is this something that we think you should use, and how comfortable are you, understanding all of it? And we kind of make that decision together.
Yeah.
And if you're a candidate for that, we try to get that in you as quick as we can and get you to the specialist, because there are more tests and more interventions that can be done to get that stroke relief.
I want to go back to something you just said. Oh, thanks, Carrie. Appreciate that. Actually, Dave appreciates that, right, Dave? You see that comment, Dave?
Oh, I'm trying to read it on my screen. Yes. Carrie, thank you.
It's nice. Going back to your comment about it's important that we get the CT scan quickly. Maybe it goes a little bit to the treatments. Why is getting a CT scan quickly really helpful for making decisions, Dave?
Sure. So let's say you're having a stroke. You're having these symptoms, right? You can't talk. You can't move one side of your body. There's two kinds of strokes. There's the stroke that forms that little clot that goes and blocks things off. But rarely there's the stroke that is actually bleeding. And that's because that terminal blood vessel there popped because it was an aneurysm, because the wall was weak, something happened. And you can have overlapping symptoms. You can't really tell 100%. So that CAT scan is going to help us determine if you're bleeding or if you're not bleeding. Because if you're bleeding, you're not going to be able to get that clot busting medication, and the treatment is going to be different for you. So that's the thing we have to know right away. Bleeding strokes sometimes have a much worse prognosis. People can do very, very poorly if they're bleeding inside of their brain, because this is a fixed space. It can't expand, so it can start squeezing your brain and really create big, big problems. Yeah. So that's really why.
What are the I forget, but it's pretty high percentage of strokes are not the bleeding type, but I don't remember the actual numbers. Any sense of that?
Yeah, it's less than 10% are the hemorrhagic type.
Or the bleeding kind. Yeah. But you got to do the CT, because if you give a clot busting medicine, it just makes that bleeding all the worse.
Right. It would just make it worse, and probably a very bad outcome for that person.
Yeah. Good. Okay. Well, we are pretty well done with our conversation. I did want to give you an opportunity, any shout outs that you wanted to give to the folks that you work with there in the ED?
Well, I saw Carrie threw a little message in there, so I appreciate that. We have an awesome team of docs and APCs, nurse practitioners and PAs that really, carry this heavy load. Everybody that comes in gets seen. Everybody gets seen very, very quickly and with a lot of compassion and skill. We have really great nurses that you kind of form these bonds with, and these family ties with them, really, who get so much done. We talked about these orders that they can get done right away. It's become part of their process in their brains where they just get things done before I can even see them. Half the things, or more than half things that I want done, boom, they're already done. So it's really a blessing, right, to have the kind of folks working there that we have. And of course, my partner and my friend, Sarah Alvarez Brown, she does most of the real work in the department. So I really appreciate
Sarah's the ED director. Yes.
Yeah.
So good. Well, Dave, thank you for taking the time to join us. Appreciate all that you and your team do down in the ED. And I bet you we'll have you back again sometime.
All right. Well, I appreciate it. Thank you very much, Dr. Bird.
All right. Thank you. Appreciate it. Bye, Dave. So for those of you listening, thank you for watching us this week. I'll be back next week. And next week, we're going to talk colon health with Dr. Al-Zubi, one of our GI doctors. And we're going to talk all things colon. So have your colon questions in hand as we start talking with Dr. Al-Zubi next week. And until next week, thank you for watching and have a great week.